At the beginning, I would like to sincerely thank Professor Aid Al-Qahtani and Dr. Osama Sani for their tremendous effort and continuous support in helping us achieve our goals. I would also like to thank Ms. Ala and Mr. Mahmoud for their great cooperation ensuring the success of our activities. Our meetings will be held periodically across all regions. Participation will be open to everyone, with the exception of Ramadan, Eid holidays, and official public holidays. My colleagues and I, as regional heads, are fully committed to doing our best to make this an outstanding academic year. Today, we are honored to have with us Professor Mohammed Al-Naimi, who truly needs no introduction. He's a consultant and director of Rehabilitative and Metabolic Bariatric Surgery Program in Prince Sultan Humanitarian City in Riyadh. The session will be moderated by Professor Awad Al-Qahtani. He's a consultant bariatric surgery and surgical oncology at King Saud University Medical City. And Dr. Khalid Al-Rashidi, consultant bariatric and advanced laparoscopic surgery, and he's the director of Bariatric and Metabolic Surgery Center at King Saud Medical City. The floor is yours, Prof. Naimi.
السلام عليكم. بسم الله والحمد لله والصلاة والسلام على رسول الله. Thank you, Dr. Ahiba, for inviting us to this virtual meeting, which I hope will be the beginning of a very successful year for the SASMBS activities. And we are all committed and supporting SASMBS in their activities, and I hope we will be successful in conducting tonight's session. And while awaiting Prof. Michel Gagne to join us as a speaker, I would like to give some introduction to tonight's activity, which will be a lecture conducted by Michel Gagne about magnetic surgery. And after he finishes, I would like Prof. Awad Al-Qahtani and Dr. Khalid Al-Rashidi to moderate the question and answer session after the lecture by picking the questions online, and will be asked one by one. First Dr. Awad and then Dr. Khalid, alternating to ask Michel the questions of the audience. As well as if you have personal questions, you have the privilege to do that before checking the virtual questions. After the completion of the question and answer session, which should not pass beyond half an hour, then Dr. Ahiba will introduce the J&J company topic, because they have a short presentation after our session tonight as the host of this meeting. And after that, we will conclude, inshallah. So can we proceed, Dr. Ahiba?
We're just waiting for Dr. Ghani. I think he's joining now.
Okay. Michelle, are you with us?
He'll be there shortly.
Okay.
بروف النعمي أو بروف عوض, if you can give us a brief summary about this magnetic surgery لحد ما يدخل الدكتور قنية.
طيب تفضل بروف خالد.
So this type of technology is really new, and Michel Gagné is the leader for this type of magnetic, which mean they can do the anastomosis without using stapling or suture. The benefit of this is the risk of leak will be decreased, and also the stricture and the stenosis would be decreased. If you look to the evidence behind this, maybe Dr. Michel Gagné, he will give us more about this, but it's not that strong, but it's promising that the future of this technology will be maybe in one day replacing the stapler and also the suturing. If you look to the cost effective and the economy, it's decreasing the cost and decreasing the time of the surgery, which is really good. The learning curve is not that like the stapler. So based on the studies, it's maybe 4 or 5 cases, max 10 cases, you can start doing this type of technology. The issue, and this is, I think, one of the issues, one of the most important things we should discuss with Michel is regarding, is it late anastomosis, or we can do it as immediate anastomosis? Because in this type of technology, we should wait after we apply the magnet, we should wait 7 to 14 days to have the mature anastomosis. Also, maybe one of the limitation is it's limited cases. We should apply this technology in a limited cases and a limited procedure. And I think in his presentation, he will give us more about which type of procedure we can do using this type of technology.
As you said, Abu Khalid, thank you very much for this introduction. And the other benefit of this procedure, this can be done for high-risk patients who cannot be anesthetized for a long time and who have other risk factors. So maybe this can be done endoscopically with conscious sedation, and the anastomosis will be done for those cases as well. And more to hear from Michel Gagné, whom I hope he will join because this is our bedtime and he's still working in his clinic. So if you, Dr. Rahiba, can someone send him a WhatsApp message to join as soon as possible before everybody will leave.
doctors. This is Muhammad Amr from Johnson. I just wanted to share our sincere pleasure and gratitude for you inviting us to join this meeting. Can you hear me?
We can hear you.
Yes, we can hear you.
Thank you.
دكتورة هبة.
هلا والله. أنا على تواصل معاه، إن شاء الله الآن بيدخل.
Can we make the presentation of the J&J company before?
Yeah, we
So
can
to
start
save
with that.
time.
Yes. Sure.
Dr. Muhammad Amr,
يا دكتور أمورني.
the floor is yours to present your share until we have Michel Garnier joining us. تفضل.
تمام. Let me share my screen. So, good evening, doctors. Again, thank you very much for this great pleasure to be with you, part of this program. My name is Muhammad Amr. I'm the Senior Business Development Manager from Johnson & Johnson MedTech, and today my presentation is going to be on the innovation behind stapling and the latest Echelon 3000 stapler. I'm going to start by talking about brands. I want to talk why stapling fails, even in experienced hands. One of the fundamental challenges in surgical stapling is that the tissue is not uniform, not between organs, and not even within the same organ. In bariatric surgery, the stomach presents some of the widest variability in thickness and in condition. And this immediately raises the question, is this really expect that one stapling solution will behave the same way everywhere? Because different tissue conditions will require different gripping, different compression, and firing behavior if you want consistent staple line integrity. As you know, the stapling is not static. It's a dynamic process. As the compression is applied to the tissue will move either longitudinally, where the tissue is pushed distally toward the end of the reload, or laterally, where the tissue flows out due to compressive force. This movement is predictable, but if not controlled, it directly impacts the formation and the alignment of the staples. And if we look closely to the stomach and the gastric tissue, we can find significant variability along the stomach, from antrum to fundus, from posterior to anterior. So different thickness, fat content, edema, inflammation, they will all impact how the tissue will react to compression. Again, in bariatrics, it's the precision is important. The control over the shape of the gastric sleeve will impact the weight loss outcomes, will impact the structural restriction, the function restriction, and it will impact also the post-operative acid reflux. Also with thick stomach, it can be challenging to capture, and it's also susceptible to more tissue slippage. We have seen with the staplers, the staplering innovation follows those challenges that we see clinically. And now I'm going to talk about a little bit about the brand. We have seen each generation of the Echelon stapler addresses a specific limitation. First, we're talking about controlling compression, and then powered firing and gripping, and then axis placement and control. In this video, I want you to focus, please, on two main things: the two-stage compression and the dynamic powered firing of the Echelon stapler. In the two-stage compression, the first stage is pre-compression, where the tissue is gradually compressed and is giving time to adapt. bariatric tissue, as you know, or gastric tissue is thick, fatty, and viscoelastic. So time under compression is essential. This stage helps to reduce the tissue rebound. It helps to remove the fluids, and it helps to create more uniform profile of the tissue before firing. And then the second stage is focal compression, which happens during firing at the point exactly where the staples are being formed. This localized compression stabilizes the tissue as the staples are being formed. So the idea here is to create the control where it matters the most and not along the entire reload size. And now I want you to monitor the speed of the firing. You can see here when the knife encounters thicker, denser tissue, the system will automatically slow down the firing, which is the dynamic firing. This slowing down is intentional because it gives more time for focal compression. It reduces the load on the system, the internal loads of the system, and it allows to reduce the slippage and the movement of the tissues as the firing is being done. Now that you have seen how the tissues is controlled dynamically, the next question is what features in the design that helps to create this control? There are several features and technologies that work together to create this controlled behavior. We have the closed bottom channel, which increases the structure integrity, and it's not available in all the staplers. And it also prevents or helps reducing the bowing of the reload with higher loads. And we have the reloads with the gripping surface technology, which increases the resistance at the tissue reload interface, preventing or reducing the lateral and the distal tissue slippage and movement. And then we have the wider tapered anvil pockets and the bent staple legs, which work together to guide the staple legs into the anvil pockets, promoting consistent B-form staple formation, which helps to reduce the malformed staple, because without proper gripping, malformed staples and with movement of the tissue, this movement can push the staple or the staple legs laterally and distally, as we can see here in this video. And this malformed staples will miss the anvil pockets if they are moved, the tissue is moving, and this will affect the strength and the integrity of the staple line, which can lead to leak, and it can lead to bleeding. So now we can say with this great technologies, what will be the addition that the Echelon 3000 will add? The Echelon 3000 will add 3 more things. The improved access, easier placement, and more control. After achieving the consistent staple and the optimum staple formation, the next challenge will be the improved access and placement. In bariatric surgery, as you know better than me, of course, the space is limited and the angle matters. So the Echelon 3000 stapler will provide you with the improved access by providing greater articulation angle more than any other stapler in the market, and shorter also articulation joint. Improved access means less manipulations and also consistent and more stable firing. It will also provide you with easier placement with wider jaw aperture and gripping surface technology. It has the ability to capture thicker tissue of bariatric more reliably, and also the gripping surface technology reduces the movement of the tissue, which can reduce the need of unnecessary reloads in complex cases. And the third thing that the Echelon 3000 will provide you is more stable firing with one-handed powered continuous articulation that can be set at any point at 1 degree angle. It gives the opportunity to the surgeon to focus on the anatomy and the surgery and not mechanics. And finally, what I want to say is that stapling outcomes are not decided at the trigger. They are engineered through compression control, tissue management, alignment, and access. And that for you as a bariatric surgeon, understanding those mechanics can give you the opportunity to choose the right staple that will work with the tissue and not against it. Thank you very much.
Thank you so much. Dr. Ghani is there. If we can start, please. Dr. Ghani.
Hi, Michelle. You are
Hello,
muted.
Dr. Michelle.
Hello, thank
Hi,
you.
hi, Michelle. How are you?
Very good, thank you.
I'm
Meet-
Mohammed Al-Nami. I'm the chairman of this session. And also Dr. and Professor Awad Al-Qahtani. He's co-chairman as a moderator, as well as Dr. Khalid Al-Rashidi, who is also co-chairman and moderator for this session. May I introduce Dr. Michel Gagnier. Michel is a graduate of McGill University in Montreal, Canada. He obtained 2 fellowships, one from France in hepatobiliary surgery and one in Leahy Clinic in Burlington, USA, in GI surgery. And as you know, Michel is the founder and the introducer of laparoscopic sleeve gastrectomy that was approved as one-stage procedure. And since then, Michel is being innovative in most of the bariatric surgery procedures, moving to endoluminal bariatric procedures, then recently adopting the magnet surgery. We all know Michel as an innovative, smart doctor. And we welcome you, Michel, for tonight's session. And the floor is yours to talk to us about the linear magnets in bariatric surgery.
Thank you very much, Prof. And thank you for all of you that are attending late for you this evening. And for me, it's lunchtime. So I will go ahead. My disclosures is that I am a co-founder of this company called GT Metabolic, who makes linear magnets, and also of this book that I wrote during the pandemics on magnetic surgery. Now, the magnets that are currently approved in more than 13 countries are the 3 centimeter, that is only in the US, and then the 4 and 5 are all of the other countries. 4 centimeter and 5 centimeter, they are made for small bowel anastomosis. As you know, the neodymium is a rare earth, and there is competition to get this metal that goes into super magnets. But it's complicated because China is the provider at 270,000 metric ton, and the United States is number 2, and Myanmar is number 3, and then there are smaller countries. In the US, there's only one mine in Mountain Pass, California, and you have to, from this extraction, combine it with iron and boron to make a mixture that is heated, and you have to mold it in various shapes. So there's a whole intermediary process that is complicated, and a rare company making this. And once you have the exact shape, it has to be magnetized. Believe it or not, it's not a magnet, and it becomes you have to magnetize. Now, the magnetic pioneering goes back to more than 40 years ago. In fact, almost 50 years ago, especially the Russians who made their experiments in using magnet for gastrointestinal anastomosis. In humans, it was used in colorectal anastomosis in 29 adults and in 1980. So this was before the era of laparoscopy and minimally invasive surgery. So in open surgery, you're using bulky rings to make anastomosis, and it was working. A lot of this pioneering work is back to Moscow in Russia at the Filatov Children's Hospital. And there are lots of publication only in Russian around that time before the USSR collapse. After that, everything disappeared. The research team didn't have any funding. And then we lost track of this experience, valuable experience by the Russian. These were the pioneers, and I thank them for initiating this at the Children's Hospital, like Isakov, Stepanov, Geraskin, and so forth. Today, we have linear magnets, and they were designed for laparoscopy and endoscopy. So we have linear magnets that can be attached in front of the endoscope that can be delivered by, in the lumen of organs attached to a catheter. And you have octagonal magnets that are in the channel of the endoscope. So there's a limitation to the force and the shape of that. And circular magnets from Magnum Moses from University of California in San Francisco. Also children used in pediatric surgery by Dr. Michael Harrison. So these were the choices used in humans presently. Of course, we are all taught that anastomosis have to be done immediately in my residency, and this might be changing now that we can do an anastomosis that is delayed in time. And there's an advantage to delay the anastomosis. If you position the magnet and then get out, you have a slow progression, a slow anastomosis, no immediate bleeding, no cutting of organs, decreasing the risk of leaks as the anastomosis happen around the magnet, not between the magnets. Between the magnet is a central necrosis. There's a bunch of instruments to deliver the magnets at the right place. You need catheters that holds it when you transport it by endoscopy. You need these laparoscopic positioner device. These are surfers. If you have it in the stomach, the duodenum, the intestine, or the colon, you can surf the magnets externally by having these laparoscopic instruments. And you also need to have non-magnetic instruments because you don't want to have the magnet stick to all the instruments and retractors. The magnet has a central core of neodymium, but because neodymium is toxic to the body, and because this is a temporary implant, we have to cover it with titanium or special plastic, silicone, or whatever, such that the body does not come in contact directly with neodymium. We have also in the second generation designed a flange that holds where the healing takes place. And this flange is absorbable materials, the same as your monofilament absorbable suture that you use in bariatric. This dissolves quickly in the lumen of the stomach or the bile, pancreatic juices, intestinal bacteria. It dissolves in 14 days. And that's where it's no longer pinching the normal healing tissue, and the central necrosis happens, and the magnet will pass in the lumen, the pair of the magnets. There's this force is increasing with approximate distance, and as the attraction happens over time, the magnet's almost touching, but there is still a scaffold of cells in between. If you put this in 2 lumen of intestine, when the magnets are expelled and you open them, you will see a very tiny letter, millimetric letter that is made of the scaffold of all the cells you have in that tissue. You can see here that in the center, you have the pill cam that is used now clinically the patient swallow this, and you take pictures of the GI tract, but this is beside the swallowable magnets that we have, and next to the battery. If we elongate magnets, we make longer anastomosis, and this is a difficulty if you have a design that is circular, because there's a limit to the circular magnet. It will not go through the lumen of the intestine, or certainly the ileocecal valve, or any narrowing. So if you have a linear design, you can increase the anastomosis, but still it will go into a smaller lumen. So you can see the pair of the magnet next to this pill cam that is swallowable. Magnets in linear are between 32 millimeter up to 80 millimeters. So depending if you need to make an anastomosis with the small bowel, the colon, the stomach, we even have biliary magnets. So these are currently the small bowel magnets, the 32 to 50. And you have to have a single magnet permits perfect alignment. No matter how you put them, they will always align perfectly. It's different if you have several magnets in a collar. This is tricky. They have to be exactly the same because they can be off, and then you will have a connection that will give you off magnets. So this is why we think that one single magnet is better. And here's the decomposition of the magnet. It's attached to a catheter, and you can release it or reattach it if you need to. These are laparoscopic positioner. They come in different force. They are thicker as the magnet is stronger. So it goes from 12 Newton in terms of force to close to 27 Newton. And you need to have variable forces because of the thickness of the tissue. If you're inside the stomach is very thick, you need a higher force than if you're in the colon, a thin wall. You can use a 12 Newton to transport the magnet from point A to point B. They're laparoscopic, and they go through the trocar. Now, remember, you cannot have a metal trocar because your magnet will get stuck inside. So they have to be plastic trocars. You can retrieve magnets if you've lost them, or if a pair of magnets stays in the colon and is not moving and you need to retrieve them. So you need endoscopic magnetic retriever. They can go into any endoscope, lumen, and you can, for example, if it's in the duodenum too far, you can pull them out and reattach them. This is a liver retractor made of titanium, and we're going to see more and more instruments that are non-magnetic, like bulldog clamps, like liver retractors, and even laparoscopic instruments now made of different metals. Here, this liver retractor is made of titanium. Bulldog clamps if you do a delivery at the ligaments of Treitz. So we started with a concept because we need to establish the concept of magnetic compression and anastomosis. And we started with the duodeno-ileal anastomosis because that's the first gesture of really a SADI or a duodenal switch. And these experiments goes back to 2008. So I've been working on this for almost 18 years. It takes time to sell a concept. This is a a comparative study between control animal growing versus the ones who had duodenal-ileostomy. You see the endoscopy shows a nice anastomosis, and patents were obtained in 2008 with this double endoscopy between the duodenum and ileum anastomosis using two magnets. So it goes way back. This is the founders of GT Metabolic with two engineers and myself, and we've been around for 5.5 years. So very quickly, we went to animal studies to clinical studies in November 2021, the first human. So it's only 4 years of experience. These are the first prototypes. They were inadequate for human use. you can see that the catheter was attached to a promontory, and this was not getting well when it was turned the other way. We redid these prototypes, and this is the first 3-centimeter prototype, and we started commercially with the 3-centimeter magnet for small bowel anastomosis. During the autopsy of the animal at 6 weeks, you can see very minimal adhesions surrounding the anastomosis, and this was confirmed in humans. At the enterotomy, it was a very bad scar tissue using monofilament absorbable suture, and we were able to compare that by histology. We had very good demonstration of the layers in the wound healing. Now, why do a magnetic anastomosis? Because it is a better and stronger anastomosis. And this we know from Dr. Harrison's work at UCSF. He did in the primates anastomosis of the small bowel and compared that to staple. The burst pressure was higher with magnets. The Russians knew that in the small intestine of the rabbit, hand-sewn control versus magnet. And you can see at any time in the wound healing, the burst pressure was higher than hand-sewn anastomosis. More recently, a nice Chinese study in rats did exactly the same. Gastrojejunal anastomosis with magnets versus control, and you can see that the operative time was very dramatically low to make an anastomosis. There was adhesion score was dramatically less. It's called the Nair score, much less outside adhesions with the magnetic anastomosis. They look at granulation tissue in histology, the surface area of the granulation tissue, and it was dramatically less with magnets, and so forth. So the MAGD, which is a bariatric metabolic operation, magnetic duodenal is different than a SADI. SADI is a end-to-side duodenal, and here we have a side-to-side anastomosis. Now, there are some advantages to that. You can, by maintaining the natural duodenum, you can go to and do an ERCP for bile duct access. You can have better absorption of minerals and vitamins because a lot of minerals are absorbed by the duodenum, and less anemia with this. And it is reversible in that you can fire one shot of the stapler and you're done. The advantage of this also is to stimulate the ileum for production of GLP-1 and PYY336 and being on a so-called like Ozempic-like medication. It's reversible, but you can also improve it. You can staple just below the anastomosis on the duodenum and transform a MAGD to a SADI. So if someone doesn't lose enough weight, you can get 100% flow with an end-to-side. You can also transform this to a complete duodenal switch. So there is modulation with this operation. The magnets pass by defecation, and 1/3 of the patients don't see them pass. We close mesenteric defect. There's a little drawing of the mesenteric defect between the transverse colon and the ileum. And this is a MAGD without gastrectomy for type 2 diabetes. So there's no gastrectomy, just the magnetic anastomosis. Now, the magnets can be delivered distally into different ways. Swallowable is one. Short colonoscope delivery to the trites is another one if someone doesn't want to swallow. You can make a direct enterotomy proximal to the site where on the ileum you want to make an anastomosis. That's very quick, a 1 centimeter incision, and then you deliver the magnet distally. And there's combination of an even double swallow in which The first magnet is swallowed, goes to the small bowel. The second magnet is swallowed just before anesthesia and is transported to the duodenum with a laparoscopic positioner device. This eliminates complete endoscopy because in many parts of the world, surgeons don't want to have access to endoscopy. It's a laparoscopic assisted procedure because you need to measure the intestine and you need to make sure that the two magnets get together without interference of other organs like greater omentum, part of the colon, mesentery of another bowel, etc. You measure the intestine, and at 250, you put a marking on the mesentery. And if you do delivery with an endoscope at the trides, you have to clamp the jejunum just below so that you're not getting distension of the whole small bowel. This is attachment of the regular gastroscope. You don't need any special endoscope, triple, quadruple lumen things, just a simple endoscope, and it's a simple endoscopy. Is the delivery at the ligaments of trides and catching with the laparoscopic positioner to drive it to the 250 centimeter mark. The second endoscopy is to bring it to the duodenum, and then they get docked. And you can see in this cartoon, after compression and passage of the magnet in the distal small bowel, they always go where the peristalsis is going, and you get a double lumen. Here's the first human with Dr. Abuladze in Tbilisi in November 2021. These are some of the intraoperative pictures. And it got to a paper as the first of human of 5 cases. And you can see each of the 5 cases with their pair of magnets, 3 centimeter magnet in the right upper quadrant. Now, this was done with a sleeve gastrectomy, and it's like a SADI-like surgery, and it led to 80% excess weight loss at 1 year. It also led to a drop of hemoglobin A1c of 2% and a drop of glucose of 47 milligram per deciliter. The second generation came into a longer magnet at 4 centimeter and now 5 centimeter, thinner, not as wide, so easy to swallow. We've done more than 500 procedures worldwide. We've never had a patient who was not able to swallow any of the magnets. That is 4 centimeter, 5 centimeter, and 6 centimeter. This is a video showing the film done in Tbilisi of a swallowable magnet for type 2 diabetes. This is obviously without gastrectomy. So the patient comes in the morning, fasting, swallows the first magnet with water, a sip of water, and then we give them a lubricant, mineral oil, 1 glass, and this will go around the intestine and will be a lubricant for surfing. 2 hours later, an X-ray demonstrates that the magnet is below the iliac crest. On the left side, it's in jejunum. On the right side, it's in the ileum. We bring the patient to the operating room. We put a liver retractor and make sure the duodenum is free from adhesion. Some patients had cholecystectomy, and the duodenum can be stuck in the liver, so you need to break down those adhesions such that a 5 centimeter to 6 centimeter anterior duodenum is free of any adhesions. In male patients especially, we split the greater omentum, just like I do my gastric bypass or duodenal switch. In duodenal switch, I will split the greater omentum on the right side at the level of the pylorus and measure the intestine with umbilical tape. You can use marked instruments. We use a 250 centimeter mark because that's where I do my SADI, and that's where I do my duodenal switch as well, learn from Picard Marceau in Quebec City. We use titanium medium large clips on the mesentery, usually a centimeter or 2 below the intestine on each side, such that if we, when we measured, we had a twist, we want to make sure by measuring it again from the making sure there's no twist. Now I'm looking for the magnet, so I brought my laparoscopic positioner device, but interestingly, instead of catching it in the proximal jejunum, I caught it in the middle of the jejunum, but I have to continue rotating the bowel so that I don't get any twist from proximal to distal. I use a traumatic bowel forceps, and I do a clockwise rotation, and you can see here we are advancing on the jejunum, and eventually we will get to the magnet. It's interesting to note that this was more than 2 hours after swallowing, and you can see how fast in some patients it can get to this position. We give them intravenous metoclopramide, which accelerates the gastric emptying, and the magnet moves from the stomach to the duodenum and so forth. Walking helps to get peristalsis, and this is surfing of the magnet from its jejunal position to its ileal position to where the clips are located. It's important, here we see the clips, and I went a little bit too far, maybe 10 centimeters away, and I have to backtrack to the clips. At the same time, the endoscopist had introduced the magnet in the duodenum attached to a catheter, and then you will dock them. They can only dock one way, and they're very strong. Once they're docked, you can micro-position this by pushing or pulling a little bit. And here you can see I seem to go across the pylorus, and you can do an endoscopy again, making sure that your magnet is sitting well in the duodenum and not going across the pylorus. If it is, I can push it slowly, gently, more distally. If it's too far in the second duodenum, I can bring it, slide it back. Here I'm sliding away from the pylorus. Now, once this is done, I will close the mesenteric defect with a running stitch. The anastomosis is done. Time will make this anastomosis, and the mesentery is closed by lifting the transverse colon upward on the left side. And here the assistant is lifting the transverse colon, and you can see the mesentery of the transverse colon on one side and the mesentery of the ileum. They usually unite in a U. You should be able to see this U, and we close this with non-absorbable suture to prevent an internal hernia in the future. I know that people do it in Saudi Arabia, mini gastric bypass, and some of you don't close mesenteric defect, but in the animal, over 100 of animals, I had 2 pigs that died from internal hernia. So I'm thinking that this is a possibility in humans. Of those 500 cases that were done worldwide, there was never a single mortality. And there were small bowel obstruction in a few cases, and they came from inadequate closure of this mesenteric defect or from adhesions to the down in the pelvis and the intestine from previous surgery, things like that. So intestinal surgery is not is a risk for bowel obstruction in the future. So I want to tell you about some of the results. This is 112 patients collected between 3, 4, and 5 centimeter magnets for duodenal ileostomy. And you can see the 5 centimeter, it's not linear, it's exponential. So the longer the magnets you have, the more weight loss you're going to get, the more flow it will go through the duodenal ileostomy, and it will get very close at a 5 centimeter magnet, very close to a complete SADI at 80% excess weight loss at 6 months. This is the Journal of the American College of Surgeons, and I was told a few days ago that this paper was the most cited and downloaded paper of the whole year at the Journal of the American College of Surgeons. And this is the side-to-side duodenal ileostomy for type 2 diabetes. We did only 15 subjects in Tbilisi, Georgia, and they had a body mass index of 33. This is stage 1 obesity with type 2 diabetes. And you can see the hemoglobin A1C before surgery was 8.2. Around 60 minutes of operation, the anastomosis was done with 2 magnets without gastrectomy. The median expulsion time was 24 days. We had 100% connection with the magnets, and 3 subjects were not aware that this was passed. You can see here there was modest weight loss. The percent of excess weight loss, this is stage 1 obesity, so body mass index 30-35 gets 44% excess weight loss, but dramatic drop of hemoglobin A1C and glucose. So this is an anti-diabetic operation that we need to work on to identify the best patients that will need this surgery. All I can tell you is that after a short follow-up, we had already half of the patient not taking medicine for diabetes. And we're going to follow this at 2 years because there is still effect beyond 1 year with this operation. The gastroileostomy is a nice development between the antrum and the small bowel. It's at 300 centimeter mostly, so a bit longer common channel. And it is similar to a SASI or a transit bipartition. This is in the pig with magnet long and 80 millimeter magnet in the stomach, 1 in the small bowel. And you can see the anastomosis we get on the outside and on the inside. This is another pig with the marking stitch and very nice connection and inside, no inflammation. So after the swine confirmation, we went to do this in the human, a multi-institutional study. We have now 49 patients in several countries like Canada, Portugal, Cleveland Clinic in Abu Dhabi, and Chile. We used the 60 and 70 millimeter magnets. We also did 80 millimeter magnet only in Canada, but we found that the anastomosis may be too large for this metabolic and bariatric effect. So this is a cartoon of how it is done. So we have several sizes of magnets, and the 70 millimeter, if used, is too long for swallowing. It is brought by gastroscopy under sedation. The magnet is attached to the catheter in front of the endoscope and is brought through the pylorus in the second duodenum and released. We allow 2 or 3 hours later for migration of this magnet from the duodenum into the proximal jejunum, and an X-ray confirms its position in the upper jejunum. By laparoscopy, we remove this magnet with a laparoscopic positional device anywhere between 250 to 350 centimeter proximal to the ileocecal valve that was measured ahead of time. A second magnet is brought in the stomach, mainly in the antrum, inferior position of the antrum, and the laparoscopic positioner advances the ileal magnet to get in contact with the one in the antrum. The catheter is released, the laparoscopic positioner device is removed, and then those magnets over time will approximate. Over 3 weeks, central necrosis will happen in the center, and the absorbable material surrounding will dissolve between 2 to 3 weeks. After passage of the pair through the anastomosis, this will get. So the mesenteric defect is also closed the same way we did with the Magedy. And this is a picture of a human with 80 millimeter magnet post-op the next day. You can see there's a distance between the two because the antrum is thicker, and it will, in this particular patient, passed 2 weeks later. This is 2 weeks later. The magnets are gone, and here we show the mesenteric defect closed to prevent an internal hernia. We published the first experience in humans in the Journal of Gastrointestinal Surgery. As I said, we have 49 patients with magnets of 60 and 70 millimeter. The 60 millimeter is swallowable, and the patient swallowed this one, so we eliminate the sedation gastroscopy in the morning, and we find that this is more appealing to the patients. The characteristics of the first cohort, you can see we only had one diabetic. This is post-sleeve gastrectomy patients with weight regain. The body mass index was 37, and we had some adverse event, but mostly have been Clavier Dindo 1 and 2. And the percentage of excess weight loss reaches close to 70% at 1 year, so it's excellent for weight regain after sleeve gastrectomy. There's an effect, anti-diabetic effect, but since we only had one patient with type 2 diabetes, I cannot comment, but I imagine it will be as strong and even stronger than the duodenal ileostomy, in my opinion. The patients were extremely satisfied, and all of them said 100% would recommend this to a family member or a friend. So it's quite promising that this gastroileostomy is also going to be used in oncology for pancreatic cancer, unresectable problems in the duodenum, duodenal cancer, biliary cancer, ampullary cancer that causes an partial obstruction. Will be able to use these magnets and make a safe surgery. Now I will finish. I know the time is flying, and the jejunal ileal bipartition side to side is a last concept, but it's really to show that you can do a lot of procedures with the small intestine with 5 centimeter magnets. The idea here with Dr. Martin Fried, the previous president of IFSO in Prague, he's doing this laparoscopically with the stapler, but we decided to change the stapler to 2 magnets between the bowel at 100 centimeter from the trites and 150 centimeter from the ileocecal valve side to side, so no bowel limbs is blind, and closing of the mesenteric defect to prevent internal hernia. So we started in Prague and did a series. And the interesting thing is we had patients who double swallowed the magnets. The first magnet is swallowed, an X-ray is taken to confirm it's in the jejunum. Then a second magnet is swallowed, and the magnet is let to progress also in the small bowel, where they unite together between 2 bowel loops. Obviously, it's probably not the best place, but we went by laparoscopy and uncoupled the magnets and then surf them at the adequate site and redock them. So there's no endoscopy in this particular procedure. It's completely laparoscopic. And these are some of the intraoperative pictures of the gesture I just told you. And the mesenteric defect that is large is closed with non-absorbable suture. The interesting thing about this cohort is that when the magnet went through necrose and formed an anastomosis, the patient who had continuous monitoring of their sugar dropped. And this was before they passed the magnet by defecation, because the magnet has to go through the ileum, small bowel, to the whole colon and get out. It takes a day or 2 after the anastomosis has taken place. So we could confirm the anastomosis with the sugar drop in the patients. So this is quite incredible. And although we had no endoscopy to confirm the connection, we had these MRI could show the anastomosis. And we also have one patient who had a pill cam and was able to demonstrate a wide anastomosis using 2 magnets in the intestine. Each of the patients had a drop of hemoglobin A1C and had modest weight loss. So a side-to-side small bowel anastomosis again is demonstrated. Instead of duodenum ileum, this is jejunum ileum, and a similar concept of type 2 diabetes reduction. So this is all I can show you, but the future is coming, and in my opinion, we'll see more procedures being done.
Thank you very much, Michelle, and really interesting and amazing subject. And I'm sure we have lots of questions to you. So if I may ask Prof. Awad Al-Qahtani and Dr. Khalid to introduce the questions to you, please.
Hi all, and thank you very much, Dr. Michel Ganier, for this excellent presentation, and I really like this technology. So we got from the audience, there was a question, which is, do we need to fix the magnet to prevent misalignment? And do we need x-rays post-op just to make sure it's passing?
Yeah. So as opposed to our competitor in GI windows, they need to have an X-ray to make sure that they're well aligned, because they're made of 8 magnets. This was in my presentation as a danger of misalignment. Here, we only have 1 magnet. They are necessarily going together exactly perfectly. So there's no problem about that. If we do an X-ray, it is to confirm that the pair is together before the patient is discharged, either at the end of the same day or the next morning. That's usually when the patient is discharged. And it is used more as a baseline to follow the progression of the magnets. Now, what's interesting is that we have put clips in the mesentery, and you can see on X-ray the clips that usually is 3 centimeters below the pair of magnets, and they never moved in relationship to those clips. Out of all the hundreds of patients we've done, there was never any migration of this pair. So once they are together, they really get deep in the tissue, and even they can't move out of that position. So the X-ray is to use as a baseline more than anything else. Now, out of 500 more plus cases, we've never seen the magnet undocked. I'm always worried that if the magnets have been put into a tension position, because there's a tendency to believe that the magnet can be done in high-risk patients, in high BMI patients, but the problem is you have an anastomosis that can be under tension. And I tell our beginner who start this, don't use your highest BMI patients when you start to do this. You would not do that if it was your first gastric bypass. Like anything, there shouldn't be any tension at the anastomosis. It's not because you have 2 magnets that the tension is no longer a valid variable in your anastomosis. So make sure there's no tension. If there is tension, you can put retention sutures on each side to release a little bit of the tension. In fact, our competitor has also said that in their instructions.
Dr. Khalid Al-Rashidi.
Thank you, Professor, for a scientific presentation. We have a question from the floor. Any issue with the anastomotic ulcer in a patient with no gastrectomy?
Yes, we put the patients on PPI, all of them, because and the patients who had a previous sleeve is usually not ulcerogenic unless the sleeve was not done properly, and now you have a stomach that is almost like the initial stomach. That's an issue. Maybe this patient also need to have a re-sleeve, but normally on sleeve gastrectomy patients, there's no ulceration on the duodenal ileostomy side. We've seen 1 or 2 ulceration. Some patients were complaining a little bit. Endoscopy was done. There was a tiny millimeter ulcers, and these patients were put on PPI. You have to look for H. pylori on these patients. For the gastroileostomy, we put all of them on PPI because it's a potential ulcerogenic operation. As you know, in gastric bypass patients with a tiny pouch, 15% of patients get ulcers. And so if you now have a large stomach connected to small bowel, the risk is higher. And I think you need to prophylactically put them on PPI, and you have to tell them ahead of time.
Do you see If you compare SADI to MACD, do you see any difference in malnutrition?
Well, the SADI is end to side. So I think Dr. Torres has transformed MACD to SADI. I think there's a couple of patients that I'm aware out of 500 plus. So we don't have a lot of data, okay? I've not had to transform a MACD to a SADI, and we have a paper that is coming out on all the nutritional variables of MACD patients and also compared to MACD patients. And this is quite interesting. We've looked at all the minerals possible. We've looked at all the vitamins possible, and we see less mineral and vitamin deficiency than a full SADI or duodenal switch patients. So that confirms our suspicion that having a partial flow through the duodenum protects patients from more severe malnutrition and vitamins and deficiencies. Now, we had a protocol, and these patients were under very tight surveillance with a nutritionist at least the first year, and all of them were taking minerals and vitamins. Now, that consisted of multivitamins every day, calcium and vitamin D every day, and iron and vitamin B12 every week. So with that, we kind of avoided most deficiencies. What was common is iron and vitamin D.
We have one also question from the floor. What are the contraindication, and if there is any complication has been reported?
Yeah. So in those protocols, we made a big list of contraindication, obvious this severe psychiatric disorder, pregnancy, previous colon resections, any disease that would narrow the small bowel, like inflammatory bowel disease, severe intra-abdominal adhesions, things like that, because the magnets have to pass. If you look at the PillCam literature, you will find that the PillCam is even used to find a stricture of the small bowel site. So we contraindicated severe diverticular disease, for example, because I was worried that a narrowing of the sigmoid colon would prevent migration of the magnets. And we've never done use the magnet in abnormal tissue. For example, in Crohn's disease, we don't know how the magnets could behave. We don't know how the magnets could behave in a peritonitis or infected abdominal cavity, because there's a lot of patients, a lot of surgeons would like to use it to treat a fistula. I have several calls of endoscopists asking me, can we use the magnet to treat fistula? So complications, I've alluded already to small bowel obstruction. We've seen a few small bowel obstruction. I'm aware of a couple of small internal hernia where the defect was not closed correctly. A knuckle went in, a laparoscopy was done, this was removed, reclosed, and then the patient went the next day. There are some more severe bowel obstruction down in the pelvis that requires prolonged hospitalization. There were small tear of the serosa of the small bowel when there is not the adequate forceps or force for transporting the magnet. So there's a learning curve to that. And most of them occur in the first 10 cases. After that, people understand how much force and what instrument to use. So you can get a tiny serosal tear that requires a stitch. If you missed it, you can have a small peritonitis from these. Some are self-healed. Some require re-laparoscopy and closure with a stitch. As I said, there's never been a mortality, and there's a learning curve of this. We just started 4 years ago to use this technology. If you were look back at when the stapler started in the GI tract, well, there were leaks, there were all kinds of problems, and now look at where we are now. So after improvement and understanding what to do and what not to do, things we know better. In the 3 centimeter, which we no longer use, makes a too small anastomosis in the small bowel. We've had a 15% stricture rate. Some of them, the gastroenterologists went in and aggressively started to dilate these small anastomosis, and a couple were perforated. So they require a laparoscopy and closure. In one, there was a laparotomy, closure of this immediate perforation, and the patient did fine. So this is possible in terms of complication. There can be bowel obstruction. Everything is intestinal here.
So based on what you select your size?
Yeah, as I said, we started with a small size and we decided to go safe and then increase the size of the anastomosis on the small bowel. In the stomach, we went the other way. We started with a large magnet and then started to decrease it to see where the limits are in anastomosis. So on the small bowel, if you want the biggest weight loss, you're going to use a 5 centimeter magnet. But there will be more flow and you're more susceptible to get nausea and GI symptoms like more frequent bowel movements if the patient are not changing their eating habits. That's the other variable, is how the patient behave to the operation. If they just continue their life as if nothing changed and they drink a lot of sugar, they're going to get dumping syndrome and they're going to get symptoms. So there has to be nutritional modification when you do these surgeries. On the stomach side, we started with a very long magnet of 8, and we realized the anastomosis was very large. So we started to decrease 1 centimeter at a time. We went to 70 millimeter. The anastomosis was very nice. And then we went to a 60 millimeter because we want to have a swallowable gastric magnet. And still to this point, the anastomosis looks good. And the 60 might be a super popular for the stomach, and the 50 will be super popular for the small bowel.
And also there is one question: how durable are the outcome in the cohort with the longest follow-up?
Yeah, it's 4 years now. What I can tell you is that in Belgium, in Georgia, where some of the early patients were done, they were re-endoscoped, and the anastomosis is still patent, because there was that question, will it close over time? The answer is no. If it's well done, it will remain open, just like when you do your jejunostomy in a Roux-en-Y gastric bypass or a Brown anastomosis for another purpose. They remain open. So that's the first answer. The second is the effect of weight improve. Well, we thought that at 1 year we were going to be done. So we had a 1-year follow-up on most cohort. And I said to myself, well, let's take a look at 2 years on some of the patients. And we look at 2 years and they lost more weight. So the data we're presenting you is 1 year, but at 2 years, interestingly, they continue to lose weight. And this is the problem of hypoabsorptive surgery as opposed to restrictive surgery. With hypoabsorptive surgery, the patients keep losing a small amount of calories and fat through these anastomosis, and they lose a very small amount slowly over time. People think that, oh, it's like a sleeve, and the patients don't understand why they're not losing a lot of weight like a sleeve. It's not the same concept at all. It's a hypoabsorptive concept. So when we look at 2 years, they were losing more weight than at 1 year. So usually it stops around 2 years and then it maintains at the third, and we only have a few patients at 4 years.
So how we can avoid overcompression, and what is the easy or the simplest way to convert side-to-side ileoduodenostomy to end ileoduodenostomy?
sorry.
So it's the opposite.
The sound was strange. Can you repeat your question slowly?
So how you avoid overcompression?
Overcompression
from the magnet, causing
well,
necrosis.
No. That became with experiment in the animals. The magnets are made so that they're not overcompressing. Because if they're overcompressing, you'll get an early necrosis and potentially a leak because the healing will not have enough time to take place when the magnet necroses and gets out. That's you'll see in some of our competitor, the magnet comes out too early. And that's worrisome. In some patients, you might be getting a leak. So we've designed the compression to come out between 2 and 4 weeks. The peak is 3 weeks. And that allows 3 weeks of collagen deposition around. So will it happen that the patient will have a magnet expel at 2 weeks? Occasionally we have 2 weeks, but still 2 weeks is 1 week away from the most dangerous period of an anastomosis, which is usually 7 days. So overcompression, it's the design of the magnet where the strength of the magnet and the shape and the surface area was designed not to be overcompressing.
Okay, so what is the simplest way to convert side-to-side ileoduodenostomy to end ileoduodenostomy?
Well, an endoduodenal ileostomy, you need a lumen because otherwise the patient will be vomiting, in the recovery room because of accumulation of fluid. So you need a window magnet. These are magnet, the linear without a window, are made for side-to-side anastomosis, such that the anastomosis is not immediate. If you do an end-to-side, like a SADI, it requires a lumen magnet, okay? We have windowed magnet, and we're not releasing them at this time because we want the concept of a non-windowed magnet to go through because that's the safety. The safety is with the windowed magnet and you have a hole in the middle. If it offsets or slides a little, you'll have a leak. So it is potentially more prone to problems like a leak or an abscess, a small chronic leak in the area. So we don't want the magnetic surgery to have a bad name. And at the moment, we want people to train and we want people have experience with the non-windowed magnet first.
Have you done more than one magnetic anastomosis in one procedure like Rowan-Y?
No, because those two let's potentially you do 2 magnetic anastomosis. One of the pair magnet will, if it is the distal one, that's fine. It will go and get eliminated in the colon. But let's say the proximal, the first upper anastomosis, moves out first, it will go and stick to the magnets in the lower anastomosis. And if it is in another bowel loop, you'll get a connection between that bowel loop and the lowest pair. So at the moment, we cannot put 2 pair of magnets in the same patients unless we find a way that the anastomosis occur at different times and that the lowest anastomosis migrates first.
So in case of failure of the anastomosis, what's your strategy?
Well, we've had anastomosis on all the patients. We had strictures. We had strictures, and I had gone back a couple of times to redo the anastomosis with longer magnets. That's the strategy.
Is there are cases of dumping syndrome?
Yes.
And what's the cost in compared to stapler?
Yes. So So dumping syndrome is possible, as I've alluded before, in the nutrition. Nutritionist following the patients and making sure they're not eating the wrong food and choosing the high protein, low fat, low sugar diet. And most of the time, the patients are cheating and they get dumping syndrome, they get dumping symptoms, and some of them get changes in their bowel movements, and they can tell they've been eating the wrong food. So the cost, it's variable from one country to the next. Like, it's not being distributed in Saudi Arabia at the moment. We have submitted the papers for acceptance in Saudi quite some time ago, and we hope and expect that the regulatory body of Saudi Arabia will give us the permission to distribute the magnets in Saudi. It's in the Gulf. In a few countries, it's presently in Qatar, UAE, Abu Dhabi, and Dubai especially. And I expect Kuwait to happen pretty quickly. So the cost, we hope that the cost will be similar to the usage of a stapler with cartridges. So that you have something similar. The 2/3 of the cost is often the distribution. So the manpower in your country to go around and teach the surgeon, be there for their help. And this is what is more costly than the price of the magnet itself.
So the
I
last
think,
question,
تفضل.
just is really important. This question is the learning curve for the surgeon.
Yeah, the learning curve is very short. We have estimated that it's 5 to 10 cases, depending on the skill of each surgeon. Some pick it up very quickly. Some need more time. There are two learning curves. There's a learning curve of the endoscopist, if you have an endoscopist participating, because sometimes it's not the surgeon, it's a GI doctor. And GI doctor, in between you and me, takes more time than
But I think he
surgeon
can do
endoscopy.
it without GI. He can swallow like 6
Yes.
hours, and then 2 hours, like before the
Yes.
surgery, he can swallow, right?
Yes, of course. There are techniques to do it without endoscopist, but these are slightly more advanced technique. I would say at the beginning, it's best to have a backup endoscopist because the patient, although we've never seen a patient not be able to swallow, but sometimes what we see is that a magnet can get stuck in the middle of the sleeve because there's a twist or an angle or a narrowing, and then you have to go and retrieve this magnet by endoscopy. So you may need to have an endoscopist in your team. The learning curve of the endoscopist is very short, 5 cases, and the surgeon is 5 to 10 cases. If you do gastric bypass, you can do this.
Okay, thank you very much, Prof. Michel Garnier and Dr. Awad and Dr. Khalid. And we apologize for the audience who asked some questions and we could not answer because the time is in essence now. It's bedtime in our country, and I hope we can hear more about this in the near future with more evidence and studies, so we can be encouraged to invite this procedure in our country. I will leave the final conclusion to Dr. Heba Al-Faris, the chair of this of the SASMBS activities.
Thank you so much, Dr. Garnier, for this insightful talk. C'est
Thank
vraiment
you.
un plaisir de vous avoir avec nous. Et à très bientôt.
Super. Merci beaucoup. À la prochaine.
À la prochaine.
شكرا.
للجميع أرجو التسجيل للحصول على ساعات CME. أرسلتها آلاء في الشات. Next meeting is going to be next Tuesday إن شاء الله بتاريخ 26th of January الساعة 8:30 بإذن الله مع الدكتور مالك المطيري. Thank you so much. Thank you everyone. Bye.
Thank you.